Hey, everybody. Welcome back to the Healthy, Wealthy, and Smart podcast. I am your host, Karen Litzy, owner of Karen Litzy Physical Therapy in New York City. And today I'm really excited to talk about hypermobility disorders. We did an episode on this last year, and so many people reached out to me to thank me for doing an episode about hypermobility disorders. So today I'm thrilled to have Dr. Linda Bluestein. She is a recognized expert in hypermobility disorders and founder of the medical practice Hypermobility MD. She also leads Bendy Bodies, a coaching service supporting individuals with hypermobility. Dr. Bluestein hosts the Bendy Bodies with the Hypermobility MD podcast, sharing insights with the community. She advocates for hypermobility research, serving on several advisory boards. So, Dr. Bluestein, welcome to the podcast.
Thank you so much for having me.
Like I said, I got so many emails and so many positive responses the last time we did a podcast on this topic. So I'm really excited to dive in. But before we do that, I would love for you to tell the audience why you decided to focus on this patient population.
Yeah, it was kind of decided for me. So, like with a lot of us, so I grew up wanting to be a ballet dancer and started to get and more health problems. Was able though to finish my, medical training, residency, worked as an anesthesiologist for over 20 years in the operating room. But then I started to get more medical problems again. And somewhere along the way, I stumbled upon connective tissue disorders. And I started doing more reading and research. And I thought, wait a minute, this could literally explain like my entire life, which a lot of people come upon this the exact same way. Like, wait a minute, they kind of figure it out for themselves. And at that point, I later, couldn't really work in the operating room anymore. I had bone grafting surgery in my wrist and I got CRPS, and it's kind of one thing led to another. And so I needed to figure out, what am I going to do now? And my youngest son was going to be going off to college. I knew that I would be very depressed if I didn't have something to do. So I thought, well, maybe I could write about hypermobility disorders. Maybe I could focus on pain management in hypermobility disorders. And then one of my colleagues, my mentor, Dr. Pradeep Chopra, he said, you need to open a clinic. And I was like, really? And he said, you're an anesthesiologist. You understand cardiac physiology, respiratory, musculoskeletal, neurology. Like you have a very broad basis of medical understanding, and there's desperately lots and lots of people who need help. So you need to do this. So he talked me into it. And so I ended up opening a clinic and then starting my first podcast, then a second podcast, which is currently the Bendy Bodies podcast. So yeah, it kind of evolved from there. It was not something that was a part of my grand plans.
Yeah, like you said, it usually never is, but somehow it finds you,
Right.
right? It finds us somehow. Now, how much information did you get on hypermobility disorders in medical school?
So you have to keep in mind, I graduated from medical school in 1990. So what I can remember was maybe like a sentence or two.
Yeah.
I hope that it's a little bit more now. Well, I would love for it to be a lot more now, but I know for a fact that it's not. But I think I literally got a sentence or two about hypermobility disorders, and maybe, Marfan's might have been rolled into there, like connective tissue disorders as a whole might have been like three
Right.
sentences. Yeah.
Right. And I've heard a lot of that similar description of how much pain science
Yes.
you physician. So you've kind of been able to combine both of them. Now, as an anesthesiologist, you might get more than the average physician, right?
Right. Because we had to rotate through the pain clinic. So
Mm-hmm.
we all
Mm-hmm.
had to do that. And then I actually did pain medicine. I did like epidurals and celiac plexus blocks, and I did a variety of procedures like that when I first finished my residency at my very
Mm-hmm.
first job.
Mm-hmm.
But then I went to a practice where they already had enough people doing the pain clinic, so I worked just in the OR then for the next 15 plus years.
Got it. Got it. Yes, I've had a couple of epidurals myself. I'm
Uh-huh, me
very
too.
have had a few. Okay, so let's get into now the joint hypermobility disorders. So why don't we start with some definitions,
Sure.
right? So we've got, of course, it's medicine, right? So we use a lot of abbreviations.
Hmm.
So let's start with HSD, which stands for hypermobility spectrum disorder. So, can you define what that is and how one might present with those symptoms?
So I definitely can describe that. Can I back it up one
Yeah.
notch though and start with JHM? So JHM stands for joint hypermobility. And that means that a joint or a group of joints has greater than expected range of motion. And we should be looking at, norms for that age, sex, race, et cetera, because that does impact how much joint range of motion is expected. So, but that we should start with that. And then hypermobility spectrum disorders is when you have joint hypermobility and you have symptoms that may be related to your joint hypermobility, but you don't have a condition, another condition to explain your symptoms. So you don't have, for example, Down syndrome. A lot of people forget that people with Down syndrome
Yep.
have joint hypermobility. So if somebody has that, then you don't diagnose them with, another condition because you have an explanation. So
Mm-hmm.
joint hypermobility is kind of the foundation that I like to think of, even though joint instability is probably even more important. You're a physical therapist, so you're probably very used to assessing joint instability and joint
Mm-hmm.
hypermobility. But for someone like me who didn't do, a physical therapy type of training program, assessing for joint hypermobility is easier for us. Learning to use a goniometer is easier than learning how to assess joint instability.
Right. And actually, that goes right into my next question is how do you um, diagnose? What are some valid and reliable uh, um, observations or diagnostic tools that physicians, physical therapists, etc., might be able to use to help us diagnose some of these, to help us diagnose.
Right. So the Biden score is something that probably a lot of people are very familiar with. I don't like the Biden score, but it is unfortunately, very well known. It's the nice thing is it's super quick and easy to learn and memorize and use and apply in the clinic setting. So it's not a bad thing to assess for, but we should always remember that this is just one small piece of information. It's not the be all and end all. So kind of almost regardless of what that number is, you're going to want to look at other joints. So basically, oftentimes we start with the Biden score, which is, can you touch your thumb to your forearm? Can you bend,
Mhm.
when you bend back, when you extend your fifth finger, does it extend by more than 90 degrees? And for that, you're looking at, the first metacarpal. You're looking at the fifth finger, and you're looking at this angle here. You're not
Mhm.
looking at the tip of the finger, right? So that's an important point. Those are the first two maneuvers, and you're looking at right and left, and you get a point for each maneuver. And then you're looking at elbow hyperextension. Is it greater than 10 degrees? If it's 10 degrees or less, it's considered, within the normal range. And obviously, this is going to vary again by age and surgeries and,
Mhm.
arthritis and all kinds of things like that. And then we look at knee hyperextension. Do the knees hyperextend by more than 10 degrees? And then the last maneuver is, can you put your hands flat on the floor without bending your knees? The first four maneuvers are bilateral, right? And then the last one is, just 1 point. So you look to see what that score is, and then you look at what their age and what the number is, and then you also want to look to see, what are their other joints like? Do they have hypermobility in other joints? And I will often ask, do you have party tricks that you do?
Oh,
And
that's a good one.
yeah, yeah. So that way I can. I usually tell them. I usually say, "Wait, let me get my video camera ready," assuming that they've signed the consent form for photos and videos, and then I ask them to do that party trick for me, and I videotape it, and I say, "Okay, now don't ever do that ever again." And I put the video on their patient portal, so that way they have access to it. So that way they can show other doctors if they're questioning the diagnosis. If they're like, "No, no, I don't believe you," they don't have to keep doing that trick over and over and over again. Videotape
Right.
it. Keep the video, have it labeled in your phone so you can show people, but you don't have to keep doing it over and over again and having that wear and tear on your joints.
Right. Right. Yeah,
So,
that makes
so
sense.
yeah, so that's what I like to start with, and then again, looking at other joints, whether it's okay. What other joints do you have either that you can do party tricks with, or that they're painful, they feel loose to you, they feel unstable, and kind of assess that way. And then also, there's another tool that's really helpful called the 5-point questionnaire. So the 5-point questionnaire asks the first 2 points. Just like the Biten score, can you now or could you ever touch your thumb to your forearm? Can you now or could you ever put your palms flat on the floor without bending your knees? And then the last 3 questions are, as a child, could you contort your body into strange shapes or do the splits? And then the next one is, as a child or teenager, did you dislocate your shoulder or kneecap on more than one occasion? And then the last question is, do you consider yourself double jointed? So on the 5-point questionnaire, if you answer yes to 2 or more of those questions, it's highly likely that you have generalized joint hypermobility. So it's important to distinguish between generalized joint hypermobility and localized or peripheral joint hypermobility. So peripheral joint hypermobility is when it's in the hands and the feet, but not elsewhere.
Hmm.
If you have localized joint hypermobility, you have hypermobility in perhaps like your hips. Maybe you have hip dysplasia or something, even to explain that, right?
Right.
So if you have localized joint hypermobility, it's just in a couple of joints. If you have generalized joint hypermobility, it's in multiple areas of your body. And if you have historical joint hypermobility, that means you were hypermobile in the past, but you're not anymore.
Oh, that's interesting. And as the practitioner and someone, you're taking people through this, through these questionnaires and observation, what are you starting to build in your head? I know that's like a broad question, but can you take us through your sort of differential diagnosis in
Hmm.
your head that you will then kind of speak to the patient to?
Yeah, definitely. Because there are people who think that they are hypermobile and they're not. I mean, that's rare. That's really quite rare. But there's people who suspect or are worried about that. And not only are they not hypermobile now, they have like 0 on the 5-point questionnaire and like none of their joints are hypermobile. I've literally had this happen to like, a sister of somebody who's a patient of mine. And they're like, oh, I'm worried that this is me too. And it's like, no, you have diffuse arthritis and that's why you're in pain, but you don't have Ehlers-Danlos. Like, that's very clear. But anyway, so what I'm looking for is the triad of things that you see with the Ehlers-Danlos syndromes. So Ehlers-Danlos syndromes are the most common hereditary disorder of connective tissue, and there are 14 different subtypes, and the most common subtype is the hypermobile type. So what we're looking for there is, does the person have joint hypermobility? Do they also have changes in their tissues? Like their tissues are weak. Maybe they have, abdominal hernias. They've had, pelvic organ prolapse, and areas where their tissues are clearly weak. And then also the other third part is, do they have changes in their skin? So they might have mildly stretchy skin. They might have soft velvety skin. They have abnormal scarring where their scars are wider than you would expect them to be, but also thin. So we're looking for those kinds of things, and that's what I'm starting to put together in my mind. Is are these does this person present with mostly musculoskeletal problems? So maybe they have joint dislocations, subluxations, tendinopathies, bursitis, joint pain, or do they have those things and also have, some of these other signs that we look for with the Ehlers-Danlos syndromes?
And what are the red flags, if there are any?
Oh, yeah, there's definitely red flags. So the vascular form of EDS is the most life-threatening form. So people have died of the hypermobile type of EDS, but it's usually related to like other sequelae. So, they end up having a bowel perforation and get septic and that's something that can happen, but it happens less often with hypermobile EDS than with vascular EDS, where the blood vessels are very, very fragile and that person can pass away at a very young age from rupture of the aorta, for example.
Mhm.
So we definitely want to be screening for vascular EDS. There's certain things that we look for, like spontaneous pneumothorax. So that's where air gets between the lung pleura and the chest wall cavity. So that's something that we might see. Might see dislocated hips at birth, club foot. Those people tend to have more peripheral joint hypermobility. So you would see the hypermobility in the hands and the feet. You see significant bleeding and bruising. So, a lot of people with hypermobile EDS do have more easy bruising and maybe a little bit more easy bleeding, but this is like bleeding, not
Mm.
not just a little bit more bruising and that kind of thing. There's also some typical or classic facial features that we might see. So you see like a thinner nose, very thin lips. Sometimes you see lobeless ears. So those are some of the things also that we see.
Right. So you're as your patient's in front of you and you're, doing your whole evaluation, all of this is going into your mind and
hmm
you are kind of making this diagnosis. So how do you speak to the patient about this? They're coming to you, they know they're a little stretchy, a little bendy, and I maybe they're having pain and they've been having some other things that maybe they can't explain, right? I'm sure that comes to you a lot. So how do you speak to them in a way that's not super scary?
Well, the thing is, most of my patients have already done a lot of research,
Yeah.
and they are very, very knowledgeable. They teach me things every single day, and I'm not just saying that just to be cute or clever.
Mhm.
They really, really do. They are very, very wise. And so usually they already know about vascular EDS. They know about
Mhm.
Marfan syndrome. They know
Mhm.
about these conditions that are life-threatening. And oftentimes they're really, really worried about it. And what's challenging is, I had a client the other day, somebody that I was coaching. I wasn't seeing them as a patient. But they had done a genetic test and they got back a variant of uncertain significance in a gene that can be related to Lewy Dietz, which is another connective tissue disorder. So they did what all good patients do. They Googled Lewy Dietz, right? And they were like looking to see what are the list of symptoms that are associated with Lewy Dietz. And they went check, 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 check. Like they had a lot of the symptoms, right?
Mhm.
But they didn't have the more specific symptoms. They had a lot of the much more vague symptoms like joint hypermobility, the tendinopathies, joint pain, these things that are not very specific. So
Mhm.
that's why some of these really, really specific, like, organ rupture, these are very, very important findings that you see with the vascular form of EDS.
Mhm.
So usually when I have patients that are worried about vascular EDS, I'm already looking for these things and I'm listening for, these very, 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 very serious medical problems that they
Right.
likely have already had. And if I'm not hearing any of those things, a lot of times they still want genetic testing to be done, but I usually try to explain to them that, you don't have anything that worries me about vascular EDS. I feel very confident that you don't have one of the more rare types either, which, those have their own very specific findings.
Yeah.
And that's where it's tricky because the hypermobile type is probably fairly common. The classical and vascular types are the next most common, but then the rest of the subtypes are actually quite rare. So most of the people that I see have either hypermobile EDS or HSD.
Yeah. And this may be a silly question, but I'm going to ask it anyway. Are all of the things that we are talking about, joint hypermobility and various forms of EDS, are they all under the umbrella of a connective tissue disorder?
That is not a silly question at all. At first, I think the teaching or the thinking was that hypermobility spectrum disorders was maybe, people were hypermobile. We weren't really considering those connective tissue disorders. But then I noticed a shift in the way, like the Ehlers-Danlos Society was speaking about these conditions. That I literally sent Dr. Hakim, who is their medical director, I sent him an email and I said, I'm confused because I thought that we were thinking that HSD was more of like a musculoskeletal condition and not a disorder of connective tissue. And he wrote back and he said, no, we're kind of considering it still under the umbrella of connective tissue, but not necessarily like a hereditary disorder of connective tissue like Marfan's, Lewy Dietz,
Mhm.
and EDS.
Got it. Got it. And when we're talking about connective tissue, would you mind listing what the body's connective tissues are? Just so that people who are watching that maybe they aren't in the medical field know what a connective tissue is.
Sure. So connective tissue connects everything to everything else. We actually only have four types of tissue in the body, believe it or not. So we have connective tissue everywhere. So it's, our tendons, our ligaments, it's in the walls of our intestines, our skin. I mean, it's everywhere. And really, the other way to think of it is it's our extracellular matrix. We used to think that these were quote unquote collagen disorders, but now we know that it's
Right.
not simply collagen, right? It can be anything involved in the extracellular matrix. So basically, that's everything except for our cells,
Right. Which is a lot, right?
which is a
So
lot. Yeah.
So to your point, under that umbrella are some of these joint hypermobility and EDS, but it might also be like rheumatoid arthritis or maybe lupus or scleroderma, right?
Yeah.
Which is, I guess we would say the opposite, maybe on the opposite end of the spectrum as hypermobility.
Oh, that's a very good
Maybe?
question.
I don't
Well,
know.
yeah, yeah.
Well, actually, because it's the connective tissue, your joints can actually still be hypermobile, but scleroderma can still be present. I don't know.
Yeah, I'm not sure about that combination, but
Yeah.
those are what you just listed. Those are all acquired connective tissue disorders,
Hmm.
right? So that's the significant difference, and those are autoimmune conditions. But we now think that the immune system is probably very important in the hypermobile form of EDS, and that's why we've had so much difficulty finding a gene or a group of genes responsible for this phenotype.
Mm.
Phenotype meaning clinical picture. And speaking of phenotype, there was a fascinating study that was done recently that looked at, I believe it was psoriatic arthritis, rheumatoid arthritis. I think it was maybe classical EDS, hypermobile EDS, and HSD, and maybe one or other category of patient. And they did like Western blot analysis, and they actually found that the fingerprint or basically the like chemical marker for hypermobile EDS and HSD in these groups of patients were basically the same. So for these other conditions, they looked different. But people that had been labeled as having hypermobile EDS and those that had been labeled as having HSD had a very, very similar set of markers. So it's very, very possible that we're making this very, very artificial distinction, but they're not actually different conditions. And of course, in medicine, this is what we do, right? We look for patterns, we make up names, we pick criteria for that condition, and then we change our mind a few years later, and we change up the criteria, and then it takes a bunch of years for everyone to get caught up. And so, it's not like we had some higher power that told us this is what these things are. We humans are trying to sort all this out.
Sure, sure. And with improved research comes different thoughts and outcomes and things like that. Now, what is the research like around these disorders? I mean, is there a lot of money pouring in to have better research? Like what is the status?
Well, let me first tell you what I think is a pretty funny story. So, I was writing an article on the perioperative care of EDS with my mentor, Dr. Pradeep Chopra, and I'm an idealist. I had these fantasies. This is going to be in the New England Journal of Medicine. Like this is going to be this amazing paper. Because I'm thinking back to when I was working as an anesthesiologist and how little I knew about these conditions and how important they are. When you're positioning somebody for surgery, if they have a connective tissue disorder, you're much more likely to have a nerve entrapment or nerve compression and have some kind of post-op complication. You're much more likely to sublux or dislocate a joint. You're much more likely to have a problem with instability of the cervical spine. So you need to be much more careful when you're doing intubations. And after you put somebody to sleep, like their jaw is going to be looser and all of these
Right.
problems that are really, really significant. So I'm thinking this is going to be huge. Like, everyone's going to want a piece of this. Oh my gosh, I was so wrong. We could not get it published in like the smaller journals, and we ultimately did get it published, but it took a lot of attempts on his part of submitting it to different journals. And ultimately, we had to pay to get it published, which I used to think that if you had to pay to get your article published, it was junk. But now, having gone through this process myself and knowing that he and I were very, very diligent about our research and everything, no, that's absolutely not the case. Anyway, that was a small digression. I apologize. But
Please.
it's that we don't have the kind of funding that we need to have, especially because, these conditions affect a lot of young people and deprive them of many, many years of productivity. And especially now with COVID, like we need people in the workforce. I mean, this
Mm-hmm.
is a practical public health concern. And so we really should be dedicating a lot more research dollars to these conditions, especially because when you consider hypermobile EDS, HSD, mast cell activation, POTS, which is one form of dysautonomia or dysfunction of the autonomic nervous system,
Mm-hmm.
and long COVID, ME/CFS, like you're talking a huge percentage of people
Yes.
that if you can get them functioning better, like they can actually have a much better quality of life and contribute to society. Whereas if we don't take care of these people, what are they going to do? They're going to be on disability. They won't be able to take care of themselves. They're going to
Mm-hmm.
have mental health problems. I mean, it's just a huge, huge problem. So while we are making some progress with research, we desperately need more funding for research when it comes to these conditions.
Yeah. Yeah. And speaking of, well, can I just digress? Do you mind if I digress for a moment?
No, not
Because
at all.
because you had mentioned POTS, and I feel like people that is another one of those diagnoses that not many people are very what's the word? uh
Like well
Knowledge,
versed in.
yeah, well
Yeah.
versed, knowledgeable, and it can sometimes take many years
Oh,
or for
yes.
that to be diagnosed. So before we go on and talk about myth busting, would you mind just giving a little, like a quick definition on POTS and what it means and what it
Yeah.
is?
Yeah, absolutely. POTS stands for postural orthostatic tachycardia syndrome. And basically, what that means is when you go from laying down to sitting up or sitting up to standing, that your heart rate increases quite dramatically and you have inadequate blood flow generally to the brain. It's not a blood pressure problem, it's a heart rate problem. If you stand up and your blood pressure drops, that's orthostatic hypotension. And yes, you
Mm-hmm.
would normally get a little bit of rebound tachycardia, but this is a heart rate problem. And we believe that it's probably a final common pathway, that there's multiple different ways that you can get POTS. Some cases, it's definitely immune mediated. So a lot of people who have POTS get an infection, could be COVID, and after they get the infection, whether it's influenza A, B, COVID, whatever it might be, they never recover. And their vasculature and their neurologic system doesn't recover sufficiently to be able to give enough blood flow back up to the brain. So, I mean, there's been lots of studies looking at cerebral blood flow in these patients, and it is definitely diminished. You don't have to faint in order to have POTS. That's a very, very important distinction. And the cutoff is 30 beats per minute for adults and 40 beats per minute if you're age 19 or younger. Like I said earlier, though, we came up with these numbers. It's not like some higher power, said it's going to be 30 and 40. We just made those up. So if someone has a heart rate that goes up by 29 beats per minute and it's sustained, and you have to have the symptoms for at least 3 months, by the way. So this is
Okay.
not just, I didn't drink enough fluid one day, I stand up and I'm dizzy. This
Mm-hmm.
is sustained symptoms going on for several months. And there's other associated symptoms with this. It's not just a heart rate phenomenon. It is a systemic disorder, just like EDS and HSD are systemic
Mm-hmm.
disorders.
Mm-hmm.
So you see things like, temperature intolerance. You see gastrointestinal problems, like gastroparesis or slow gastric emptying is very, very common. It affects, your ability to sweat. And things like that. So your autonomic nervous system is responsible for all the things that we don't normally think about. And if your
Right.
autonomic nervous system is dysfunctional, you have a lot of problems.
Then you got a lot of things to think about
Yes.
when it's not working. Well,
Yeah.
thank you for that because I have close friends whose children were diagnosed with
Mm.
POTS after years,
Yes.
years. And I know
Yes.
it can be so frustrating. So thank you for shedding some light on that.
Of
Okay,
course.
let's get into some common misconceptions. And the first one, I love it so much. So when we think about people with joint hypermobility issues or matters, we always think that's a perfect person to be a ballerina. Like
Oh,
all dancers have this, right? So do
mhm.
those two go hand in hand?
Yeah. And actually, I've been seeing more and more lately people saying, oh, they're so hypermobile and talented, like as if the hypermobility just automatically means that they're talented. And if they're not hypermobile, then they must not be talented. Like, how does that
Right.
work?
Right.
Yeah, hypermobility does not equal talent. But anyway, so yes, a lot of dancers are hypermobile, especially if you look at certain groups. So if you look at elite ballet dancers, the percentage of elite ballet dancers that are hypermobile is very, very high, like 90+% in some studies. If you look at contemporary dancers, modern dancers, hip hop, other forms of dance, it's maybe going to be a little bit less, but it is still going to be fairly high. Well, why is that? Is it because it makes them hypermobile, or is it because they're drawn to those forms of dance because of their hypermobility? And I think it's probably more the latter. You can succeed at something like ballet if you are hypermobile because you can achieve those gorgeous aesthetic lines. You have the banana foot and, this, gorgeous S-shaped leg that you can achieve these gorgeous lines with. So I think that it's mostly that, but there is also forced hypermobility. So a lot of dancers are doing things like the oversplits. They're putting their foot like on block on a like a yoga
Oh,
block,
yes.
yeah, and then they have somebody push down on their knee to try to force them into that oversplit, and that on the back of the knee, it's terrible, terrible, terrible thing to do. So forced hypermobility is a term that I first heard from my Bendy Bodies podcast co-host, especially for the first few seasons, Jennifer Milner, who is a Pilates instructor and former professional ballet dancer, and she was like, these people are forcing themselves into hypermobility.
Yeah, I shudder to think about that.
Yeah.
That is just terrible.
Yeah.
Um, okay, so that's one common misconception. How about that if you have symptomatic joint hypermobility, that it only affects your joints?
Mm. Hmm. Yeah, that's a really, really common one. And it's so frustrating because, you know, we're kind of taught in medical school that if somebody comes in and they have complaints in every bodily system, or they have more than, five complaints or whatever it might be, that they must be, making it up. It's in their head. They're being melodramatic or something like that. And so we're not taught to look for things that could explain symptoms in multiple different bodily systems. Yet these conditions do exist. And if you think about connective tissue, it makes sense. It's everywhere in the body. So it's going to affect our blood vessels and our digestive tract and, the ability to, do various different things in our life. Like fatigue is a huge, huge problem for people.
Mm.
And it makes sense if you think about it. Number one, a lot of people have POTS or another form of dysautonomia, which does often come with fatigue. And they're having to work so much harder to have their joints cooperating and get their muscles to activate properly. And we also think that there's probably, at least in some people, some secondary mitochondrial dysfunction that happens because a lot of us develop kinesiophobia. I know I sure did. So
Of course.
once you hurt yourself doing a lot of like really simple things, then you're afraid to move. And some people, unfortunately, move less and less and less. And therefore, then they start to get some secondary problems related to that.
Right, right. I didn't even think about the kinesiophobia, but that makes perfect sense.
Yeah,
Yeah,
when
because
I
why
yeah,
would you
when
keep doing something that hurts?
Yeah. When I first saw that term kinesiophobia, I was writing my first paper about pain management in joint hypermobility. When I first saw that term kinesiophobia, I was like, oh my gosh, I have kinesiophobia. Then I read about pain catastrophization. I'm like, I have pain catastrophization.
Yeah, 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 yeah. And they often go hand in hand, you know?
Totally.
You were like, well, if I do this and this is going to happen and this is going to happen, I'm going to be in so much pain and I'm not going to be able to go to work. And then I'm going to lose my job and then I'm going to be homeless and
Yep. Yep.
typical pain catastrophization.
Yep. I'm really good at that. Or
A
I
lot.
should say I was really good at that. Yeah.
That's better.
Yeah.
Um, okay, so it doesn't only affect the joints, like you said, it's that connective tissue is everywhere.
Mhm.
Um, how about it's not painful, you're just really bendy?
Yeah, yeah. Unfortunately, I still see notes from colleagues that say that this person has, quote, benign joint hypermobility syndrome. And it's like, I mean, I know if you want to say benign versus cancer, okay, I get that part. But there's nothing benign about these conditions. If you
Mhm.
have symptomatic joint hypermobility, you probably have quite a bit of pain. And a lot of
Right.
people are used to being in a lot of pain all the time. So they kind of, it's funny because we kind of get sensitized to it at the same time that we learn to just push it in the background. So I feel like, quote unquote, normal people, have more of a pain switch where they're either in pain or they're not. Whereas we're just kind of used to like having pain most all the time.
Right.
But that also then can often cause allodynia and hyperalgesia, which is where things that are normally not painful cause pain, or things that are normally only slightly painful cause more pain.
Yeah. Yeah. And these are the people that I see quite a bit of because I
Yeah.
work with a lot of people with chronic pain. So I'm seeing those people with allodynia and hypersensitivity and trying to explain to them like what that means. And I do find that when you find, as the patient, when you find the person that can help explain things, like I'm sure you do, it does turn the dial down. And so
Yes.
maybe they will have less pain. Like Lorimer Mosley and David Butler. I'm not sure if
Yeah.
you're familiar with them.
Oh,
Yeah.
I'm very familiar.
Yeah.
Yes.
Yeah.
Love them.
So
Love
that's
them.
what they talk about in their Sims and Dims. So your danger in me and your safety in me. So going to a doctor could be a danger if it's a doctor like, oh, it's just, you're fine. It's all in your head. Just go exercise. Or they can go to someone like you where you'll explain and then it becomes a sim or a safety in me and can
Yeah.
actually turn the dial down.
Yeah.
So, it makes such a huge difference to educate your patient and to help them when things are painful.
Yeah. And I try to really enforce and reinforce with, I should say, with my colleagues that you don't have to become an expert in these conditions. Of course, it would be
Mm-mm.
great if you do, right? But if nothing else, if you validate their concerns and if you believe them, listen
Mm-hmm.
to them and believe them, that's actually doing something. I actually went to this training for it's a course called The Healer's Art, and it was taught by Dr. Rishi, who is this amazing physician. And, they teach you that. And at first I didn't really understand because I started that training before I opened my clinic. And once I opened my clinic and I realized even just listening to somebody, like you said, it calms down their nervous system and it completely changes things. And
Yep.
instead, if they're gaslit, if they go in and the person either accuses them directly or just implies that they are making this up or that they're lazy or crazy or there's something wrong with them or whatever, that's going to increase their stress and anxiety. And we know that psychologic stress activates mast cells, and mast cells release pro-inflammatory mediators, which also increase pain. So there's truly an actual mechanism whereby stress increases pain.
Yeah, absolutely. Oh my God. I could talk all day. Could talk all day about it. Okay, moving on though. How about the myth that if you have these connective tissue disorders or joint hypermobility matters, that, oh, well, no treatment. You just have to do the best you can. So, are there treatments?
Yes. So, first of all, that makes me crazy because, I hear people say, well, there's no cure. How many things in medicine can we actually cure? Not that
Mm-hmm.
many.
Mm-hmm.
It's like, so why would you say, let's not bother diagnosing these conditions because we can't quote unquote cure them? There's so many things that we can do to help mitigate symptoms. And I have an acronym that I use for this, and I talk about it a lot, like in my Substack newsletter and on my Bendy Bodies podcast. Men's PMMS, and the letters stand for movement, education, nutrition, sleep, psychosocial modalities, medications, and supplements. And that just kind of helps me to remember the 8 different components of a person's comprehensive treatment plan. And sometimes, they come back and we're discussing things and I'm trying to figure out, okay, well, what can we work on next? And I go through those 8 different things and I think,
Mm.
okay, let's work on this, let's work on that. It's just kind of a way for me to remember. I came up with that acronym a number of years ago for the method that I use for prescribing treatment plans for patients.
Yeah, I love that. Would you mind repeating that one more time?
Yes, no, I would be happy to. So it's men's PMMS, and it stands for movement, education, nutrition, sleep, psychosocial, modalities, medications, and supplements.
Perfect. That's great. And I love the fact that you included sleep and nutrition because the more research that I've done into pain, and you realize, well, wait a second, these are two factors that we have some pretty decent control over. And by the way, they can kind of make a huge difference,
Yeah. Yeah, and are
right?
very much underappreciated. And as a physical
Yeah.
therapist, I want to make sure that I point out, because I think you'll appreciate this. If you notice in this acronym, there's three M's. It's very intentional how they're sequenced. The first M is movement, because that
Hmm.
is the most important thing. And then the last M is medications, because while medications can be helpful, you can't just give someone a pill and expect them to feel better. You need to work on all of those things.
Absolutely. Absolutely. Oh, I love it. Okay. So are there any other common myths that we missed that you can think of?
Boy, I think you hit the really, really big ones. I think the last one that I want to point out is, some people think that all hypermobility is EDS. And I mean, I remember during the Olympics, people were like, oh, that person has EDS and this person has EDS. And it's like, first of all, you can't tell by watching someone on TV.
What do you mean you can't tell?
So stop diagnosing people that are on TV. I mean, and it's also really harmful to the community at large because, already there's so much stigma, right?
Hmm.
Like there's doctors that are like, oh, this is the TikTok disease or something like that. And it's like, we need to be very, very thoughtful of how we use these terms and make sure that
Hmm.
we are getting, properly evaluated and, following guidelines and also using common sense though, because with the 2017 criteria that came out, it starts with the Biten score. And while I think the Biten score is a great tool, if somebody doesn't have a high enough score on the Biten, I still will go on and assess for the other things. I will look for the piezogenic papules. I'll look for the arachnodactyly. I'll ask them, do they have a high narrow arched palate and some of these other things? Because just because somebody isn't as hypermobile as they used to be doesn't mean that they don't potentially have hypermobile EDS.
Right, right. All excellent points. And now, as we start to wrap up, what are the big takeaways that you would like the listeners to come away with from our discussion today?
I think the first one would be to look for hypermobility because it is so important and so many people don't know that they're hypermobile. And even if they have no problems, it's still really, really helpful to know that a person has joint hypermobility because it affects their proprioception or knowing where their body is in space without looking. It can affect their risk of injury or their ability to heal from that injury. And a lot of people do go around doing party tricks and not realizing that they don't hurt now, which is fine, but they might hurt in the future. And once they start hurting, they might not be able to get them to stop hurting. So I
Hmm.
think that, the first thing is if you're a physical therapist listening or, an ordinary person, think about hypermobility. I can't tell you how many times I've been out to dinner with, kind of like a relatively random group of people. And then you're talking a little bit about what you do. And then they're like, oh, you mean like double jointed, like this, like this. And
Uh-huh.
next thing we know, we're talking about their health problems because they're like, oh my God, nobody's ever been able to figure this out. And and they're like, the light bulb goes off. They're like shocked, and they're like, oh my God, this is a thing. I've had people literally like sobbing in tears because
I'm
they're like,
sure.
yeah, because they're like, I blame myself all these years. I thought that I was just weak or whatever. So I think it's just so important for all of us to have this on our radar. So I think that's the first thing. And the second thing is I'm so, so passionate about people having access to resources because, this whole myth that there's no treatment, so why bother is just so harmful to people. It doesn't do anything in terms of helping their psychological state, and helping them feel like, no, I know my body. We're basically saying to them, you don't know your body. You don't know what's going on in your body, but they
Mhm.
do. People really, really do. They're experts in their own body. So we should listen to them, validate them, and offer them resources and treatment options.
Absolutely. And then speaking of resources, where can people find you, your podcast, your website? They want to work with you, whether it be coaching or grabbing an appointment as a patient. Where can they find you?
Sure. So I have two companies and basically like kind of three main things that I do. So my medical practice is called Hypermobility MD, and that website is hypermobilitymd.com. And then my podcast is called Bendy Bodies, and that website is bendybodiespodcast.com. And I talk about, all things hypermobility and connective tissue disorders. And, we had an episode on sleep and, lipedema and all kinds of like related topics, mast cell activation. We talk about that a lot. And then I also have a Substack newsletter that has really been getting a lot of traction lately. And I love it because, if you're doing a social media post, you're limited to like what, 2,000 characters or something on
Right.
Instagram. So you really just can't say a whole lot, right? But through these Substack newsletters, you can really share a lot more detailed information. So I'm really enjoying that a lot. And then the last thing is the Bendy Bodies coaching that I do. So I started getting messages from people all over the world that were just so desperate for help. And it was just really hard because, I'm not medically licensed in, other
All over the
states.
world.
Yeah, all over the world. Yeah, yeah. I'm medically licensed in Colorado and Wisconsin, and that's it. So if people come to see me in Colorado or Wisconsin from anywhere in the US, and actually now recently I've said anywhere in the world, I do now see international patients. So if somebody can come see me for that first appointment in person and establish care as a patient, but then they have to do follow-up via sitting in Colorado or Wisconsin. That's the sticking point. So they have to be
Right.
sitting in Colorado or Wisconsin. It could be virtual, but they have to be
Hmm.
sitting in those states. So that's the sticking point. So that's why I started this coaching practice. Through the coaching practice, I will talk to them. It's a one-on-one. There's nobody else there. I take a history, I hear their concerns, and then I share with them. It's like I'm writing a book just for them. I'm
Hmm.
writing a journal article just for them. So say people with, maybe they told me that they have itching and rashes and hives and flushing. So people with itching and rashes and hives and flushing often respond really well to ketotifen, which is an antihistamine that is also an excellent mast cell stabilizer and also very anti-inflammatory. And this is the subject of a recent Substack newsletter, by the way. It's one of my favorite medications to prescribe. So through these coaching sessions, I will share resources with them that are customized to them, but it's their responsibility, though, also to share these with their own medical team because I'm not
Right.
writing them any prescriptions. I'm not ordering labs. I can't do that, but
Right.
I can give them this customized information.
Amazing. And just so everyone that's listening right now, we'll have the links to all of those resources in the show notes. So, whatever platform you are listening to right now, just scroll down a little bit and you'll get to the show notes, and one click will take you to all of these resources. So, Dr. Bluestein, before we end, last question. It's one I ask everyone. Knowing where you are now in your life and career, what advice would you give to your 20-year-old self?
I love that question because my 20-year-old self is so different than how I am quite a few decades later. I think believe in yourself. I think that'd be the most important piece of advice because I did get a lot of medical gaslighting along the way, but that was not as harmful as the gaslighting that I did to myself.
Mm.
I literally had a doctor say to me in the doctor's lounge, I looked inside your knee. There is nothing wrong with your knee. This is like 3 days after my knee arthroscopy. I went back to work like literally the very next day. I'm standing all day. Of course, there's inflammation. I just
The
had
next
surgery.
day. Oh
Yeah.
my God.
And, and also, I didn't even think about this at the time. Like they can't see inside my bones, inside my ligaments. He's not looking at it from a microscopic level.
Right.
I had a massive bone bruise. I had a nasty fall off a mountain bike, and that bone bruise was there for like, over a year. So instead of
Right.
yeah, so instead of thinking, well, he's a jerk, I gaslit myself. And, that was a dark time for me.
Mhm.
So I think believing in yourself is so important and showing yourself compassion and, really just trying to be loving towards yourself is the most important thing.
And that is great advice. So, thank you so much for coming on. What a wonderful discussion. I absolutely loved it. Thank you so much.
Well, thank you so much for having me. I really enjoyed chatting with you, and I'm so grateful to you for helping get the word out about these conditions because
Yeah.
they affect so many people, and people are suffering, and we need to do whatever we can to help them and help improve their quality of life. A lot of these people are really, really young; they have their whole life ahead of them, so
Yeah.
we really need to help them as much as we can.
Absolutely. And thank you again. And everyone who's out there listening, thanks so much for tuning in. Have a great couple of days and stay healthy, wealthy, and smart.